ya penyakit.
Buat time keep-nya aku langsung try.
Cuman kan yang makanya ya.
Like uniforms.
So good morning, honorable participants and honorable speakers. My name is Jeremy from AMSA International, and I will be moderating the session for today AMSA International webinar series, Current Approach Towards COVID-19 for Day 1. I would like to say welcome and thank you very much for registering and broaden your knowledge via this webinar. I hope this webinar will give full of benefits towards us all. This webinar have total of 445 registrants from 15 different countries: Indonesia, Singapore, Malaysia, India, Nepal, Bangladesh, Philippines, Thailand, Myanmar, Macau, Taiwan, Kyrgyzstan, Hong Kong, China, and South Korea. So today we will consist of 3 sessions, 2 of the lecture session by Dr. Gurbilas and Dr. Gurmeet, and the final one is the question and answer session. If you have questions during the lecture session, feel free to ask the questions during the Zoom chat column. So please ask directly and I will read aloud the questions in the question and answer session in chronological order within the 30 minutes time span. So you have to ask the questions during the lectures. It's okay. And kindly please fill the pretest before you participated into these webinars, because if you do not fill the pretest, you will not get the certificates. So we will begin without wasting another time. I will read aloud the CV of the first speaker, Dr. Gurbilas. So this is Dr. Gurbilas Singh. Dr. Gurbilas Singh is a practitioner at the Jivandip Center of Digestive Disease in Chandigarh in India, and he is a director of education and training in Sarfit Gastrocity in Amritsar, India. And currently he qualified as a MBBS in the Kasturba Medical College, Mangalore, India, and he also obtained the MRCP, the Member of Royal College of Physicians in the United Kingdom, and the Fellow of Royal College of Physicians in London, in the United Kingdom also in 2016. These are the CV of Dr. Gurbilas, and the next session I will give to Dr. Gurbilas. The stage is yours.
If you allow the share screen, please.
Yes.
Thank you very much. So thank you very much for having me here. And we're going to talk about current updates on COVID-19 diagnosis. I speak on behalf of Doctors Academy UK, GI Rendezvous, which is another organization which does awareness and education activities, and of course, Sarfit Gastrocity, where I do my regular job. I would like to start by thanking our experts, Ms. Harvinder Kaur from Malaysia, and Dr. Kanwardeep Singh, Professor of Microbiology and Principal Investigator, Viral Research at the Government Medical College, Amritsar. So a pandemic, as per WHO, is a worldwide spread of a new disease, whereas the US Center for Disease Control and Prevention defines it as an epidemic that has spread over several countries or continents, usually affecting enormous population. So widespread endemic disease with a stable number does not qualify as a pandemic. If you look at the history, there is a bit of, in the olden days, we had smallpox and tuberculosis. Tuberculosis goes on now as well, but then smallpox has been eradicated. The recent ones are HIV and COVID-19, of course. And in the recent past, we have had H1N1, as well as the Spanish flu, which took a lot of lives. So we'll try to restrict our talk to how to diagnose in clinical practice and some manifestations and variations of COVID-19, the comorbidities and how can they impact on the outcome, and a bit about surveillance. So going into the background, COVID-19 or SARS-CoV-2, it's a respiratory infection which can actually develop a severe pneumonia or can have a simple course of cough, fever, etc. Spreads by respiratory droplets like sneezing, coughing, and talking. And it also spreads from touching the surfaces and then touching your own mouth, nose, possibly eyes. And as we know now, many of the individuals can remain asymptomatic. To suspect and diagnose COVID in daily practice, we now know that most people will have fever. So fever, cough, and any shortness of breath or constitutional symptoms like muscle aches, or there are specific things like unexplained loss of taste or smell. Occasionally diarrhea and symptoms like headache can trouble people. There can be mild symptoms which may aggravate over the next week or so. And we know from data, almost 20% can become seriously ill and need hospitalization. Most of them would be with some health conditions and usually over the age of 65. We'll just talk a little bit about a case. This also has the basis on the questions that we have been asked to give to the students. So a Mr. B, a 35-year-old male, rings up for a teleconsult with symptoms of dyspepsia. His main symptoms were bloating in the tummy, a bit of heartburn, nausea, that is on taking paracetamol, he told me, and a sore throat with occasional cough. He did mention there was a bit of dysphagia, although this was only when he was taking any medication. There was a background of low-grade fever for almost 9 days in the history. But he quickly mentioned that he's already got it checked and he didn't think it was COVID as the test was negative. So here, one thing to highlight is never assume anything, and we have to take a proper history. And going in the history, we could easily see that the test was done probably on the 3rd day after he started with the symptoms sometime around Saturday night, and then Tuesday morning was when RT-PCR, which is a routine specific test for COVID-19, that was done. He said that he does get cough and, off and on during such seasons, but his oxygen levels were reasonable between 93 and 95. He was checking it at home. Most people are doing it here in India now. The family history included both parents being hypertensive and mom was also a diabetic. He was otherwise fit and well in the past with no medication, no allergies, remained a non-smoker all his life, and occasionally took alcohol. So just to explain the question, but I don't have to give the answers right now. So this is a question which will come to you. And also, this is a second question, the next step in management and where we go from what we heard in the history. And then if he's actually COVID positive, what we should be doing. I was told I don't need to explain anything right now because the questions will come to you. So we'll leave this at that. The clinical manifestation, the most common ones that we've discussed remain fever, dry cough, and some constitutional symptoms. But less common ones include diarrhea, redness or irritation in the eyes, some sore throat, and some loss of taste or smell has been certainly mentioned. If we look at the data, the most common symptom, almost 90% of the patients will have fever, and a lot of patients, almost 70%, will have dry cough. There is mention of almost 30%, 1/3 of the patients may have productive cough as well, and lots of constitutional symptoms, including myalgias and muscle pains, etc., with headaches. So the silent infection in SARS-CoV-2 makes it very difficult for surveillance and as well as for looking for real patients with this problem, and hence the spread has been phenomenal. The testing positive for SARS-CoV-2 without clinical symptoms and abnormal chest X-ray imaging has been one of the things that people have been trying to do. And there has been some acute respiratory tract infections which are very, very minor, like just some throat pain, nasal congestion, and fatigue. And the mild pneumonia, which can be with or without fever, with some respiratory symptoms, and sometimes even without any shortness of breath, has been noticed. But sometimes, as we saw, 1 in 5 cases can have severe symptoms, And severe symptoms here would mean a pneumonia, which leads to accessory respiratory muscles being used, dyspnea, the oxygen saturation is falling below 92%, and the respiratory rate going up almost 30 per minute as per the guidelines, as per what we see. And there can be disturbance in consciousness. We've seen post-COVID convulsions in patients. The patients are unable to eat more because of reduced appetite, but sometimes it could be feeding difficulties as well. And on a high resolution CT, we see infiltrates. There are also some lesser known symptoms. Thromboembolic events have been much more common in data from France, Netherlands, and China. In India, we haven't seen much of this, but they are well documented now. There is also some data on skin manifestations still being looked for, and the WHO is doing, collecting this from various national registries to look for rashes that have been seen, which are specific to these COVID-19 patients. This is a slide from Malaysia, which is a very recent thing, in which they have specifically mentioned that little more than 50% of the patients remain asymptomatic. So 1/3 can be symptomatic even without a pneumonia, and 13% will be seen with pneumonia, but there will be no hypoxia. But critically ill is just under 5% now, as per the Malaysian data, and 1% would be really critically ill, requiring ventilation and all ICU care. So at this stage, when Malaysia is going through its third wave, they have said avoid 3C and practice 3W. So avoid 3C means crowded spaces, closed spaces, and closed conversations should be avoided. And the 3Ws are washing hands, wearing masks, and warnings like physical distances. Rather than social distancing, we have started saying physical distancing now. Looking at the comorbidities, the 4 major things we have are obesity, diabetes, elderly people, and hypertension. So a meta-analysis has shown these 3 to be most important: hypertension, obesity, and diabetes. But the data also mentions that over 65 older patients have got increasing risk, especially if they have comorbidities. And this could be because the elderly people, there is usually a change in lung anatomy and muscle atrophy, which leads to some physiological changes, leading to reduction in the lung volume. And also because of the age, sometimes we face low immunity status, and that can increase the chances. The data has also mentioned one more condition which is very prominent: chronic obstructive pulmonary disease, which is a respiratory illness, and puts people with this condition to almost 4-fold higher risk of having COVID-19 as compared to normal individuals. Huang et al. And Wong et al. Have both reported all these things, that cardiovascular disease, diabetes, hypertension, and COPD are one of the major factors in which COVID-19 can be disastrous. And in the Wong et al. Series, they've said almost 37% needed ICU in normal population, whereas with comorbidities, almost 3/4 of the patients needed ICU care. The hazard ratio among patients with at least one comorbidity was lower as compared to 2 of the comorbidities if present. So definitely anybody who's a diabetic is usually a hypertensive. So that makes things difficult for elderly people, especially, who are more prone to such diseases. So this data, if we see, places hypertension as the most important factor, seconded only by cardiovascular disease and diabetes. So just highlights what we've been talking about. Now, when a virus infects, the immune response initially is an innate immune response, which means your interferons, the cytokines, the other chemicals, they start fighting with the infection. They interfere with the virus replication. And this can lead to our constitutional symptoms like fever, headache, stuff. And before we go to the adaptive immune response, step 2 of the immune response, sometimes in immunocompromised individuals or weak immune status patients, this step 1 innate immune response goes on for a longer period. If it goes on like that, it can damage more body organs, and hence it can cause severe pneumonias or severe symptoms to such patients. In the laboratory, we have got various analysis methods which have led to SARS-CoV-2 detection. These include blood, feces, anal swabs, and many other specimens that we will discuss here. In the blood work, like any other viral infection, we see leukopenia, mainly it's lymphopenia, and thrombocytopenia is also seen here. The other thing that was noticed in most patients was that CRP was elevated. These are all non-specific things. These can be in any viral infection, I suppose. The CRP has been highlighted here, although most patients with many other conditions will have a raised CRP too. The various places where we take the examination swab from, in this table, which looks slightly busy, but we can easily see the first one, nasopharyngeal swab. Now, this is the most important one and is being recommended because of the ease of taking it. Whereas oropharyngeal swab, bronchoalveolar lavage, tracheal aspirate, and things like those are used for more sick patients. As an outpatient test, as an, just going to a lab and having it done easily, nasopharyngeal swab has come out to be the most important one. So there are blood works and stools as well. But as we'll see, nasopharyngeal swab, why has become more important. This graph basically shows the immune response to viral infections. And the incubation period has been shown by various data now to be almost 5 days. So if we have done a test within less than 5 days of exposure, then possibly we'll miss the virus. So it is recommended, if something like this has been done, it's important to recheck it. Now, the symptoms usually last from day 5 to day 15. And then after that, various antibodies kick in. This graph again shows it more clearly. If we see the red part, that's where we can actually miss the virus. So a very small window period there. So day 5, even here we consider that's the best way we can catch the virus in our tests. Antibody tests have been used, but they're usually not recommended for checking the virus. Yes, the immune status later with IgM and IgG can be checked with this. However, a negative antibody test cannot exclude infection because it may be early during the disease onset. So we cannot take antibody tests as a proper tests here. This graph shows us about the antibodies, the purple one and the green one we can see as IgG and IgM. There is talk about IgG disappearing. So IgG gives a chronic state. The antibodies are present and the infection cannot happen again. Whereas IgM is the acute stage where the infection is going on. And there are patients we have seen whose total antibody status remains very high. And many of these are IgGs, which slowly come down again. But the data is still awaited as to what happens after that. So various tests being done. The nasopharyngeal antigen detection test is the main test, initial test, although it may have a slightly low sensitivity, but the specificity is pretty good. And what is normally recommended is a nasopharyngeal swab for antigen detection should be done as a first thing, because the time taken for the results is pretty small, whereas RT-PCR takes a longer time. And hence, till we wait for that, for confirmation, we can simply do an antigen detection test through the nasopharyngeal swab. RT-LAMP or another RNA test can also be used, but it's probably as good as RT-PCR, but RT-PCR is more popular as such. Similarly, if we look at the advantages and disadvantages, the nasopharyngeal antigen injection test is the easiest to do, and even with very less equipped labs, we can easily do this. Whereas RT-PCR requires some equipment which is special, and this can be done as a confirmatory test later. And there are other tests, of course, enzyme-linked immunosorbent assay and the chemoluminescence immunoassay. These are standard tests used for various other viral detections. But the rapid detection test, we take it as a weekly screening in high-risk individuals. For doctors, especially in India, it was being done for high-risk individuals who were looking after COVID patients. So this is a pretty good screening test, and data from cohorts have really appreciated this. So if we develop a small algorithm, which is basically used in India here, so rapid antigen test, if positive, irrespective of the symptom status, we reported that the patient has COVID-19. If it comes back negative and the patient is asymptomatic, then we can repeat test if the patient becomes symptomatic. Otherwise, we just leave it at that. Or otherwise, if the patient is symptomatic with fever or sore throat or cough, then definitely a confirmatory sample has to be sent for RT-PCR. There has been talk about doing CT scans as a surveillance as well as screening for patients. At least in India, there has been instances where private healthcare is accessible to patients. They simply, whenever they develop some shortness of breath or cough, they simply go and get a CT scan done for themselves. However, it should be done under a doctor's guidance, of course, and confirmatory test with PCR is important here, because a CT scan can show a pneumonia for any other cause as well. An X-ray chest may not be recommended as a first choice, because simply an X-ray chest shows only 40% of the lungs, as we know, and generally it's a vague test when it comes to specific conditions and may miss early consolidations. And HRCT would be the test to look for. In various studies and various data, abnormalities on X-ray and CTs have been compared, and we have seen a CT to be much better as a test for radiological findings for any reason, but specifically for COVID-19, a normal chest X-ray will still have clear abnormalities on a CT. There are certain other biomarkers which are being evaluated. For example, saliva, which seems to be a reliable tool, but and it could represent a valid instrument for diagnosis, but it's not being used routinely as of now. Similarly, stool. In one study, it has been shown 57% of the infected patients, they remained positive for COVID-19 in stool beyond nasopharyngeal swab, so by median of 4 to 11 days after that. And the persistence of PCR in sputum and stool was found to be similar in some studies. Also, there has been talk, we know very well from before, that respiratory infections can, affect our ocular fluid. It can, the viruses, they can come to ocular fluid. So for this reason, it has been hypothesized that we can check the nasolacrimal system also, and tears can be used to check for COVID-19. Certainly, there are other proteins like nucleic acid tests and viral proteins, antigens, antibodies, as we discussed, IgM, IgG, which can be checked. And there are, protein cell and cellular markers like CRP. CRP is, as a serial CRP, we use it for, many other conditions like starting from cellulitis, inflammatory bowel diseases. So various conditions it has been used in the past, and in COVID-19 it has been shown by various studies that a trend is very good in predicting how things will be. So an elevated CRP and even D-dimers have been shown to be associated with COVID-19 infections. And a one-off CRP may not be of helpful in any patient. So there has to be a trend that has to be noticed. So whether the CRP is coming down in due course, that would signify probably a better prognosis. Similarly, thrombocytopenia and lymphopenia, as we discussed earlier, which are vague, tests for any virus, any viral infection. So the white cell count itself can go up along with the deranged LFTs and creatine kinase. Serum ferritin, it has been noted, it's just an acute phase reactant. So just like CRP, even ferritin can go up. But I personally wouldn't recommend checking ferritins or serial ferritins for this. When we have CRP, that should be good enough. And the challenge using these biomarkers is always, the cellular markers, is that nothing is specific. They are all slightly vague and non-specific. So just summarizing what we have just discussed, an HRCT is considered to be a very good test, which would give us a good idea about the interstitium of the lung. Similarly, the RT-PCR analysis of nasopharyngeal swab, tissue sample in patients who have passed away, who are no longer there, they can still be obtained from the tissue, so we can use that for RT-PCR. And stool, again for RT-PCR, can be used. There are other tests for ELISA, and for rapid detection, we've got card tests, which are very helpful in at least initial assessment. And all these tests have been validated to do. Coming to the surveillance, now surveillance is basically to look for trends within a population, having a national registry or an international registry and looking at how we are doing, whether we are getting new cases in a particular region. So to detect new cases, it's very important so that we can risk stratify a region or a population. So for risk assessments, we need surveillance, and how we can, monitor our preparedness or guide our preparedness and response to such trends, to new cases. This is where our objectives are met through surveillance. So when we talk about surveillance, first thing we have to understand is who is a suspect. So as we all know, probably whoever has gone to a hospital, whether it's a patient or a healthcare worker, we always check the temperature these days. So it's one of the screening tests now for COVID when one has to enter a hospital. At least in India, that's a norm here. So anybody with the acute respiratory illness and fever or cough or shortness of breath, any one of the two, together with all these things, we can simply say the risk is much higher to have COVID. There's also an added factor, history of travel, because if there is a location where there is lots of cases reported and the patient has been coming from that area or had history of travel there during the last 14 days, 2 weeks, so he becomes a high risk individual, so hence becomes a suspect. Also, anybody with acute respiratory illness and confirmed contact with any COVID-19 case in the last 2 weeks becomes a suspect. Anybody with severe acute respiratory illness where we cannot explain the symptoms with anything else. So anybody with cough, shortness of breath, and fever, we can easily put it as any flu-like symptoms. But in the era of the pandemic, it becomes very important to first, check COVID-19 rather than putting it directly on any normal flu. So contact can be anybody when you have been in contact with a positive case or a high-risk individual for more than 15 minutes in a room or at close quarters within 1 meter of distance. Hence, the consultations or hence the contact with the patients, whether it's an operation theater or wherever, if it is going to be more than 50 minutes, it's high risk, and we should avoid it unless we know the status of the patient. Similarly, a direct physical contact, touching a patient or touching an individual who is a confirmed case, we become a contact with them. And if we are in the care of a patient, whether at home or in the hospital where we are looking after the patient as an attendant, we become, a direct contact. And there are other low-risk assessments or local risk assessments in various countries where they mention that these are the reasons where patients can be considered contacts. For practical purposes, so the period of contact is measured almost 2 days prior to the 14-day period. So that's what we consider a contact would be. For healthcare workers in surveillance, there are certain strategies that can be used for passive or active case finding strategies. It's easier to educate healthcare workers, anybody who's working in the hospital, and suspected cases can be easily identified if they're trained. And this could be something like, in inpatients, clinical care providers can simply evaluate their patients for signs and symptoms. A patient who's admitted not for any symptoms of COVID and develops new symptoms can be easily identified by anybody who's working in the hospital. Similarly, healthcare workers can monitor themselves, and in case they have any new symptom which can be related to COVID, they can easily tell their employers and can self-exclude themselves from work. So training and education for doctors, it may be easy, but for other workers, there has to be some sessions to train them for this. And similarly, monitor and manage ill and exposed health workers. The sick leave policies have to be monitored accordingly. And established reporting within the different healthcare facilities. This is very difficult in a country like India, but this for COVID-19 and for such diseases, certainly we all have to report the cases and we have to communicate to the public health authorities. Similarly, enhanced case finding strategies are used for COVID-19 patients. They are in place internationally. The routine surveillance, which requires that normal population, the routine populations, any symptomatic cases, including healthcare workers and frontline workers, are identified. But all asymptomatic, as we discussed about contacts, so all these people who have been contacts of high-risk patients in families, in workplace, anybody who's over 65 years of age, immunocompromised with various comorbidities, and all these patients who have been in contact with a laboratory confirmed case within the 5 and 10 day period of coming in contact should be tested. Also asymptomatic high-risk individuals. So if we can do that in a containment zone, that's what is recommended. And ideally, they say 100% people living in a containment zone should be tested by the rapid test. In a non-containment zone, for example, history of international travel in the last 14 days, all symptomatic individuals should be checked, of course, and the contact of a laboratory confirmed case, anybody who's been confirmed, and somebody living with the patient or in contact with the patient must be checked. All symptomatic healthcare workers, frontline workers, and who are in a containment zone, doing various activities, supportive activities, have to be checked. Anybody who's got influenza-like illness has to be checked. We cannot assume that this is a simple cold. And all asymptomatic high-risk contacts in the family, workplace, everywhere, and especially who's over 65 years of age, has to be checked. Within the hospital settings, there are certain things that are being done. Most patients who have been in the hospital for more than 3 days, more than 5 days become, and are elderly, they become high risk for any infections. So within the hospital, to stop the spread of COVID-19, we have to be more vigilant. And anybody developing influenza-like illness symptoms or severe acute respiratory infection have to be looked after in a different way. Similarly, patients who are going for elective surgeries, endoscopies, ERCPs, any other procedures which require hospitalization or coming to hospital, and doctors or nurses spending time with them, they require a COVID test prior to this, as do all pregnant women who are hospitalized for delivery. Just a few references here of what we have talked about. Before I end, I would like to just mention it here, as we are talking mostly to the students. So a clinician should never make assumptions. History is the most important part of our management of the patient, and this should not be missed. Since medical technology keeps changing, we have to keep abreast, and that is why it's very important that we either as peers talk about it or listen to the experts regularly. Just like clinical guidelines, even laboratory testing algorithms keep changing. We know so little about a thing like COVID-19. We would have seen many U-turns in the last 6 months, the way the patients were being managed, the way the new medicines or the old ones, which were guaranteed to be used, have been changed and then come back and then changed again. Understanding the rationale of treatments, of testing are very important. So as young doctors, it's very important to understand as well as apply it to daily routine. And we should always think about safe practices for our patients and for ourselves, of course. And preventive measures, when we sit in a clinic and we look at a patient, it is not just the condition they have come to us for treatment, it is also for preventive things, preventive healthcare, which is most important and is our responsibility as well. I would like to end by just simply showing you this slide of a collage of our activities at GI Rendezvous, where awareness and education activities are regularly being done all over the state of Punjab and Chandigarh. And we regularly, proactively get people to join us, normal population to join us in awareness activities in all sorts of medical conditions which are preventable. Thank you very much.
Thank you very much, Dr. Gurbilas, for sharing the very useful information about the approach of COVID diagnosis. And we will continue directly to the second presentations by Dr. Gurmeet Singh. I will read aloud the curriculum vitae of Dr. Gurmeet Singh. This is the curriculum vitae of Dr. Gurmeet Singh. Dr. Gurmeet Singh finished his study in the University of Kridawachana for the medical doctor, and then he took the internal medicine specialist in Universitas Indonesia, and he took the pulmonology consultant in Universitas Indonesia. And Dr. Gurmeet Singh is a critical respirology illness consultant in the Cipto Mangunkusumo National Central Hospital of Indonesia, and have much of training and qualifications. That is for the CV, and I will share the stage to Dr. Gurmeet Singh. The stage is yours. Thank you.
Yeah, thank you, Jeremy. Thank you to all participants for joining this webinar. And thank you for Dr. Gurbilas for presenting a good topic on diagnosing COVID-19. So I'll just share my screen. So is it okay, Jeremy?
Yes, it is okay.
Okay. So I'm given the opportunity to discuss about recent strategies of COVID-19 management It's in inpatient and outpatient settings. So as we know that since the first report case from Wuhan at the end of 2019, that's probably by mid-December 2019, we have found increasing numbers of cases that have been reported in other countries. In Indonesia, I think now we have around 300,000 confirmed COVID cases, and number one is still America, and the second is India, followed by Brazil. And so WHO, they have decided to declare COVID-19 as a pandemic. It's an emerging disease still being studied throughout the world for the diagnostic methods, for treatments, effective treatments, prognostic, and some other treatments. They have been studying throughout the world. There have been randomized control trials, there have been observational studies, and even in Indonesia, we have some randomized control trials for this COVID-19. It is transmitted by droplets, hence WHO recommend to follow their safety precautions in order to prevent further infection or further spreading of this COVID-19. Some procedures can be defined as aerosol generating procedures, bronchoscopy, endotracheal intubation, and the last one is nebulizer therapy. Hence, healthcare workers have to pay special attention while performing these procedures. In Indonesia, in my institution, we regularly perform bronchoscopic procedures. We have some precautions taken. We have like a limitation for the staff to accompany me or some other senior respirologist to performing bronchoscopy, and we have a negative pressure room, and we have to follow all the precautions. And regarding endotracheal intubation, I recently read an article that they say that endotracheal intubation as well as extubation, it's less aerosol generating procedures. So COVID-19 is etiology is SARS-CoV-2. It's a small virus. It has got spike protein on its surface. The spike proteins will further bind to ACE2 receptors. For healthcare workers treating COVID-19 patient, it is recommended to use N95 mask. We have got diagnostic methods right now through RT-PCR, serology tests have been mentioned by Dr. Gurbilas. These are the number of specimens that can be used for diagnosing COVID-19. Well, number one is from bronchoalveolar lavage. In my institution, we use this method, especially in critical ill COVID-19 patients. Like we recently have a case over here, twice negative through nasopharyngeal swab. The patient develops into critical COVID-19, intubated, and I just performed the bronchoscopy yesterday, and we found out that it was positive for SARS-CoV-2. And also, there's a special note over here that nasal swab will only detect around 2/3 of cases, whereas pharyngeal swabs detect 1/3 of cases. And so for unadmitted patient, it is much better to perform nasal swab testing. Let me share just one slide about the precautions or consensus from the Society of Advanced Bronchoscopy. So all societies, they recommend postponing elective procedures. Unless it is emergency, you can go on with the procedures. And we have to pay special attention in reducing or limiting this spreading of this virus. We have to pay personal PPE, personal protective equipment, to prevent exposure to droplets or aerosol. Dr. Gurbilas presented the slide about the pathophysiology. I'll just go through it in a quick. So SARS-CoV-2, once it enters the body of the patient, it will bind to the ACE2 inhibitors, ACE2 receptors. ACE2 receptors, is majority of it is found in the lungs. The virus replication of the virus goes on in the lungs before it spreads to other organs, and so the innate immunity is the first one to be activated. So a patient with a good innate immunity, they say over here that they will not develop into severe or critical COVID-19 patients, because type 1 interferon or interferon gamma will further activate the monocytes, macrophages, and this will further activate the Th1 cells and also the B cells in producing antibodies. But still, there is a recent paper that I read. Why do some healthy patients or healthy persons without any comorbidities, young persons, they develop into a severe or critical COVID-19? And they found out that probably this kind of patients, they might have a deficiency in type 1 interferon genes. So this might be interesting, statement to be further evaluated. COVID-19 phases, there's a stage 1, stage 2, and stage 3. Whereas in stage 1 is early infection, viral application goes on, the patient might be asymptomatic or in mild or moderate symptoms. Whereas stage 2, you have the patient might have some dyspnea complaint, where they will have abnormalities in the chest X-ray or in the CT. And if this goes on, it depends on the age of the patient, comorbidities of the patient, or any gene deficiency. The patient might develop into the hyperinflammatory phase. This is when the patient goes into ARDS, acute respiratory distress syndrome. And also they found out that in this population, usually we have a cytokine storm. So COVID-19 clinical presentation, you have a mild, moderate, you have a severe and critical. Mild, the patient will have like flu-like syndrome, no pneumonia, and moderate, you have a flu-like syndrome, mild pneumonia, and there's no dip in saturation. If you have a dip in saturation, that is silent hypoxia and pneumonia, then the patient is classified as severe COVID-19 patient. The patient goes into ARDS, multi-organ failure, or in a shock, then they has been classified as critical COVID-19. So it will be important to evaluate the silent hypoxia in COVID-19 patient, because usually COVID-19 patient, majority of the patient when they come into the clinic, I recently got a patient, quite okay, quite okay, just some fever and some mild symptoms. But when I do checking for this saturation through pulse oximetry, the patient has got a 90% of saturation, even though clinically he's stable. So we have to admit this patient, and the patient goes into the criteria of moderate COVID-19 patient, and there he was treated with antivirals and some other medications. So when you get a COVID-19 patient, should we treat it as an outpatient or inpatient? So it depends. The patient is asymptomatic, mild COVID-19, you can treat him or her as an outpatient. Whereas a patient classified into moderate, we have to further evaluate whether the patient can take a self-care at home, self-isolation, and there is a support from the family, or no financial issues, as we know that if the patient doesn't go into a trial, and trial usually has been done in hospitalized patient, that the patient have to pay for this antivirals and some other treatments. If no financial issues, the patient can be treated as an outpatient. Whereas if there is all these three things, not being able to do some self-isolation, no support from the family, and some financial issue, then it will be much better to hospitalize the patient. For severe and critical COVID-19 patient, there is no issue, there is no arguments. You have to treat the patient as an inpatient. Just get the patient hospitalized for further treatment. I'm sorry. Yeah, so another issue is when to treat patients with antivirals or anti-inflammatory drugs. Looking at this picture over here, so in stage 1, where the viral replication is quite high, so it will be much better to treat the patient with antivirals. There are different types of antivirals that I will be sharing in my next slides. So it will be much better to treat the patient with the antivirals, whereas the patient goes into the mid of stage 2, that is probably above 10 days, it will be much better to treat the patient with anti-inflammatories. Yeah, whereas if the patient goes into stage 3, then there is no issue of giving the antivirals to this patient, and it will be much better to treat this patient with anti-inflammatories. There is one paper that I've also read that above 8 days, or let's say above 10 days, the virus is dead in the culture. So it will be much better to avoid antiviral treatments for COVID-19 patient above 10 days of symptoms. So about antivirals, there have been studies going on, randomized control trials and some observational trials. Even in Indonesia, we're doing some RCT and observational trials. One trial that I would like to share is favipiravir. This is an open label control study. It has been done in China, Wuhan. So they compare it to lopinavir, ritonavir. We know that lopinavir, ritonavir has been used as an HIV drug. So in these two groups, one group, they give favipiravir for 14 days with a loading dose of 2 times 1.6 gram, and they continued from the second day till the 14th day, 2 times 600 milligrams, and the control arm is they use lopinavir, ritonavir twice daily till the 14th day. And from this Kaplan-Meier survival curve, we can see for viral clearance, it is much better in the favipiravir group compared to the control group. And also from this diagram of this chest CT at day 14. So in some countries, there is an issue for how long when can we give this favipiravir treatment. Some are giving it less than 7 days or 7 days. That in Indonesia, we are following this protocol. And also in some other countries, they're giving more than 14 days. We're looking at this research study being done. So there is also some benefits in giving favipiravir for extended days, that is for 14 days. As it will also give some plus point, positive results in clearing up the chest X-ray. So they found that favipiravir showed better treatment outcomes in COVID-19 patient, not only in the viral clearance, but also in the disease progression. That was favipiravir was being done in mild, moderate, and severe COVID-19 patient, and has lopinavir, ritonavir. This is being done in severe COVID-19 patients. So there are two groups. Again, one group being given lopinavir, ritonavir, and the second group just with standard care. So they found out that time to clinical improvement was much better in the lopinavir, ritonavir group compared to the control group. Whereas for the viral clearance, we can see over here that it's not statistically significant, lopinavir group and the control group. So their conclusion was in hospitalized adult patient with severe COVID-19 patients, so no benefit was observed in the lopinavir, ritonavir group compared to the standard group. But again, this was done in severe COVID-19 patients. Probably they might find some other results if it has been done in mild to moderate. Over here in Indonesia, we are still giving some this treatment, lopinavir, ritonavir, in mild to moderate COVID-19 patient, but our guidelines have been following the results of outside or some more, what do you say, research being done outside. So we have been revising, or there's a revised version for our national guidelines. Chloroquine, hydroxychloroquine, this was one of the drugs that has been campaigned as the drugs of choice for COVID-19 patients. But right now, I don't think hydroxychloroquine is being considered as a drug of choice. Probably in some countries, they are still using hydroxychloroquine, but in our national guidelines, I don't think we have been using hydroxychloroquine right now. So this was a study from the Recovery Collaborative Group. They've got study for dexamethasone. They've got study now for tocilizumab going on, where they found out that the primary outcome, 20-day mortality, and also the secondary outcome, discharge from hospital, invasive mechanical ventilation, compared to the usual group, it is statistically non-significant. and also mortality at 28 days. We're looking at the Kaplan-Meier curve. This curve goes for hydroxychloroquine compared with usual care. It's almost the same. So at this moment, the recommendation is they found out that those who receive hydroxychloroquine did not have a lower incidence of death at 28 days compared to the usual care. We see from the forest plot over here that all the variables, they're giving a positive benefit to the usual care group compared to the hydroxychloroquine group. Antiviral combination, RCT going on. Over here, they combine ivermectin, doxycycline compared to hydroxychloroquine and azithromycin group. We know that ivermectin is an antiparasite drug, antiviral effects. Doxycycline is an antibiotics, also known for its antiviral effects, and also with azithromycin group. So they compare two groups, and it is well matched. Ivermectin, doxycycline compared to hydroxychloroquine and azithromycin. Looking at all the result from this picture over here, even though it shows that the group A, which is the ivermectin and doxycycline group, gives a better outcome, symptomatic recovery compared to group B, but it's not statistically significant, giving this negative RT-PCR, even though in symptomatic and asymptomatic group. So they found out that even though the ivermectin doxycycline combination showed a trend towards superiority, but it's not statistically significant in becoming symptom-free and difference in time to negative PCR. So how about remdesivir? Remdesivir right now has been approved for FDA, has one of the drug of choice been given to COVID-19 patients. Another study from recovery trial, so they randomly assign two groups. One group, they've been given remdesivir with a loading dose on day 1, and for a total of 9 additional days compared to placebo for 10 days. Looking at this forest plot, again, if we see the hydroxychloroquine group, it goes positive results to the usual care, whereas in remdesivir group, you can see the forest plot, it is giving positive result in the remdesivir group. And some sub-analysis, they see that patients group that will be having a positive benefit receiving remdesivir group is a patient that have been receiving oxygen, whereas patient not receiving oxygen or patients with high flow oxygen or non-invasive mechanical ventilation or patient on mechanical ventilation, we can see from this picture over here that it doesn't give any benefits to those kind of patients. Even though they found out that remdesivir was superior to placebo in shortening the time to recovery in hospitalized COVID-19 patient, but it will be much better to give COVID-19 patients with low flow, or I say low dose, requiring low dose oxygen with remdesivir. How about anti-inflammatories? So another recovery trial, they found out that low cost dexamethasone reduces death by up to 1/3 in hospitalized patient with severe COVID-19. So they randomly assigned patients in two groups. The study group received oral or intravenous dexamethasone 6 mg once daily for up to 10 days. And they compare it, the placebo group, to receive usual care alone. Coming back to the forest plot, we see over here that the dexamethasone group is much better compared to the usual care group. But if we see the sub-analyzed study over here, so for patient not receiving oxygen, so there's no dip in saturation or not receiving oxygen, then there is clearly no benefit in giving dexamethasone in this patient. So patient on oxygen only, whether it's high flow or low flow, and patient in invasive mechanical ventilation, there is a positive benefits in giving dexamethasone. There's another issue, whether after 10 days we should stop this dexamethasone completely, or should we taper off the dexamethasone, as we know that we know that the inflammatory phase, it goes on beyond 10 days. So I think this is an issue to be discussed later. How about tocilizumab? We know that in COVID-19 patients, some patients, they develop a cytokine storm, and multiple cytokines are elevated in COVID-19 patients. You got an IL-6, IL-17, TNF-alpha, and also some other cytokines. But IL-6 has been studied as the most important cytokines that has elevated in COVID-19 patients. So they studied about tocilizumab. This is an observational study, and some randomized control trials are going on. So 43 patients were included, and only from these 43 patients, 3 cases of this 21 patient, they received tocilizumab in the ward, were transferred to ICU, and none of them died. And radiological improvement was also observed in severe cases on the 7th day of tocilizumab. So after giving tocilizumab to severe or critical ill COVID-19 patients, there's a downward trend of the CRP, ferritin levels, the dimer, and the lymphocyte count will goes up. So there was a beneficial for survival, length of hospitalization, and duration of oxygen support in the earlier use of tocilizumab in COVID-19 patients. So it is important to get the IL-6 value in severe critical COVID-19 patient, whereas I've seen some moderate cases also, whereas there is a dip in saturation. We get a high level of IL-6 in their blood. We give tocilizumab treatment in those kind of patient, and there is a positive benefit for the patient. How about other therapies? There's about the role and timing of plasma convalescent. So the patient, COVID-19 patient, once he or she survives, he has gone into the convalescent phase. If he or she agrees to donate plasma to be given to other patients, then it is called that plasma convalescence. So there is a trial in India about moderate COVID-19 patient. They enroll about 464 adults patients. This is moderate COVID-19 patient. It's a randomized control trial. In the intervention group, patient will be given 2 doses of 200 cc of convalescent plasma, transfused for 24 hours apart. Looking at the intervention arm and the control arm for this unadjusted risk, it is non-significant. So this says that both the group are well matched. Both the group are well matched, and they found out that looking at this serum ferritin, serum LDH, CRP, and D-dimer, there is no difference in the group that has been given convalescent plasma and standard of care compared to just a standard of care. And also the result from the study was progression to severe disease or all-cause mortality at 28 days. It's quite similar in the group receiving convalescent plasma and in the group just receiving usual care. So convalescent plasma is not associated with a reduction to progression in severe COVID-19 patient. We haven't known that how about in mild or moderate COVID-19 patient, as we know this convalescent plasma is one of the therapy being given. We use the antibodies of the survivors. So antibodies might be beneficial if you give early in COVID-19 patient or any viral patients. Yeah. So another drawback from this study was they also mentioned that the a priori measurement of neutralizing antibody was not done in donors. So this also plays a major part in the results of the patient. How about studies abroad in America? So the effect of convalescent plasma. Over here it's different compared to the India study. In Indian study, they compare about the moderate COVID-19 patient, and over here in America, convalescent plasma was given to severe or life-threatening COVID-19 patient. So even though they find out that in the 7 days adjusted mortality and 30 days adjusted mortality is not statistically significant, but they broke down again the sub-analysis, and they found out that in patient receiving convalescent plasma less than 3 days, there is with a high level of antibody titers from the donor, there is a statistically significant results compared to patient receiving convalescent plasma more than 4 days. So they found out that earlier time to transfusion and higher antibody levels, it provides a signature of efficacy for convalescent plasma in hospitalized COVID-19 patients. So this is a good issue. So whenever we want to give a convalescent plasma to our COVID-19 patient, just to make sure that it will be given in the earlier course of the disease. Looking at these results, it is probably better to give in less than 3 days since the infection. Some autopsy results or studies have found out that one of the contributors of death in COVID-19 patient is there is a blood clot. So our blood clots are one of the contributors of death. So from one study from Wuhan, so abnormal coagulation, it is associated with poor prognosis. So they found out that conventional coagulation results and outcome of 193 consecutive patients were retrospectively analyzed. The mortality was high in the non-survivals, which have a relatively significant high D-dimer levels compared to the survival with low D-dimer. So their conclusion was abnormal coagulation results, especially marked elevated D-dimer and fibrin degradation product are common in deaths. But one of the other issue is should we anticoagulate? Should we give anticoagulation therapy to all our COVID-19 patients? Or some patient might benefit with this anticoagulation therapy, and in another patient might not benefit giving this anticoagulation therapy. And the other issue is, should we give prophylactic therapy or should we give therapeutic dose in this COVID-19 patient with anticoagulation requirements? One of these studies, so they compare 98 subjects treated with heparin for 7 days or longer, and 350 subjects without heparin treating less than 7 days. So there are two variables that are statistically significant, which will give a better outcome in COVID-19 patient if they are given this anticoagulants. And there are two variables over here, but I mark 3 variables. But overall, a patient, COVID-19 patient with a sepsis-induced coagulability score more than 4, and with a D-dimer level of more than 6 upper normal limits, this patient might have a positive results or positive benefits if given anticoagulant treatment. While looking at this bar diagram also, it shows that COVID-19 patient with sepsis-induced coagulopathy score more than 5, and with a D-dimer level of more than 6 times upper lower limits have a beneficial positive outcomes by giving heparin. So anticoagulants may not benefit in the unselected patient. Instead, only the patient meeting the sepsis-induced coagulopathy criteria or with markedly elevated D-dimer may benefit from anticoagulant treatment. And mainly in this study, they've been giving with low molecular weight heparin. Should fever be treated in COVID-19 patient? COVID-19 patient, usually they come with symptoms of fever, cough. So should we give antipyretics to all of our COVID-19 patients? This old paper, it's in 1988. One pathophysiology slide that I shared with you guys. So interferon gamma or type 1 interferon, it plays an important role in the innate immune system for the activation of monocytes and macrophages. In this paper, they show that subjects, human volunteers, immersion in warm water till 41 to 45 degrees Celsius. And looking at this diagram over here, that patients, subjects with a temperature up to 39 degrees Celsius, it will give a benefit. In benefit of the interferon levels, it can produce as much as 10-fold more interferon levels. We know that interferon levels is the main what do you say, starting point for this innate immunity. You get a good interferon level, then your monocyte, macrophages, and you will have a good innate immunity. So this is one of the issue also. Should we treat patient with antipyretics? What I've been doing is, yes, I let my patient stay in a fever condition, maximum up to 39 degrees, just for 10-15 minutes. Let their innate immune system get charged, let their monocyte and macrophages get charged, and after that I give them antipyretics. Because another benefits from fever and thermal regulation is, besides it heats up, it activates the interferon gamma and then the macrophages and the monocytes. There is also evidence that thermal stress dampens the cytokine synthesis once the macrophages becomes activated. So in this regard, they found out that human monocyte-derived macrophages, they produce less TNF-alpha, less IL-6, and less IL-1 beta when exposed to febrile temperatures than heat-inexperienced cells. So I think it will be, in my personal opinion, it will be much better to keep some of our COVID-19 patient in the fever state, probably 10 to 15 minutes. After they've been charged up, their macrophages, monocytes being activated, then it will be much better to give antipyretic later. Prone position and ECMO in COVID-19 patient. Usually it is, they've been doing this prone position before also earlier in ARDS patient. They've been proning the patient and they've been getting better results in treating the severe hypoxia. So in COVID-19 patient, even though a patient is in moderate COVID-19 state, they've got a dip in saturation. It will be much better if we can keep the patient in prone position, say for 6 to 8 hours, and then getting them back in the supine position. Whereas in critical ill patient, what we have been doing in our institution over here, we have been collaborating with our intensivists. They've been proning the COVID-19 critical ill patient for around 24 hours, and they're gonna put back the patient into the supine position. So they found out that proning COVID-19 patient, it will give a better results in saturation, in respiratory breaths, and also in the ROX index. So ROX index is a ratio of oxygen saturation to FiO2 to respiratory rate. They take a cutoff of more than 4.8. They measure that at 2 hours, 6 hours, and 12 hours after a high flow nasal cannula oxygen, that we can predict which patient goes into the lower risk for intubation, or this patient might go into the high risk for intubation. Whereas if you get a ROX index more than 44.8, your patient goes into a lower risk index for intubation. Less ROA index less than 4.8, then it will be much better to intubate the patient earlier. This is a CT scan of the patient before prone position. We can see ground glass opacity, multiple ground glass opacity in both the lungs. 1 day after prone position, there is a decrease in ground glass opacity, and the other patient before proning, multiple ground glass opacity. 5 days after proning, there is a decrease in ground glass opacity. ECMO, extracorporeal membrane oxygenation, we can give in our COVID-19 patient. Usually, we give early ECMO membrane oxygenation therapy in COVID-19 patient in critical COVID-19 patient, not responding to treatment, not responding to a prone position, let's say for 3 days, less than 3 days, or probably 2 days, but some institution, they use it for 1 day. It will be much better to treat the patient with ECMO. So ECMO should be considered its use in refractory COVID-19 related respiratory failure, and it should be given early. Looking at this graph, number of patient days from ECMO initiation, and this pink color over here, it's for patient who succumb to death. Giving ECMO earlier in this patient gives a better survival compared to patient who received ECMO later in their hospitalization, we got an increase of death. Immunity boosters. We have got lots of immunity boosters that can be given to our patient, probably in mild, moderate, but studies have been going on also in severe patients, in critical ill patients. So vitamin D insufficiency has been found prevalent in severe COVID-19 patient. There's a study also going on giving high dose vitamin D in COVID-19 patient, but some papers have been recommending that it is a good recommendation that to check the vitamin D levels of the patient before giving this vitamin D supplements. But in my institution, we have been giving routinely all COVID-19 patients with this vitamin D supplementation. So what is the exact dose of this vitamin D supplementation has to be further analyzed. N-acetylcysteine is also a potential treatment for novel coronavirus. There's a recent publication in Brazil giving high dose of N-acetylcysteine, 21 grams of N-acetylcysteine to a severe and critical COVID-19 patient, and they found out that there was no beneficial in giving 21 grams of N-acetylcysteine. But we never know whether in severe, in mild or moderate cases, is there a benefit of N-acetylcysteine. But previous studies shown in the flu pandemic, also in the previous SARS pandemic, like patients or people who have been taking this N-acetylcysteine with a dose of 2 times 600 mg per day, there is less less chance of getting this infection with SARS-CoV. And if they do get infection, usually they don't go into the severe or the critical condition. Zinc is also another issue to be discussed. Every patient has been COVID-19. Usually we give zinc. We know zinc has a role in cellular mechanism in the cells. Also, it can inhibit the RN, RD, RP polymerase intracellular. But we need a zinc ionophore. Zinc ionophore, it will block the replication of this virus. So giving zinc alone is not beneficial. Zinc together with zinc ionophores will give some benefit to the patient. Usually one of the well-known zinc ionophores is hydroxychloroquine. We can give it with a dose. From the study result, they find out that zinc with the dose zinc ionophore hydroxychloroquine of 300 mg can upregulate the insertion of zinc in the cell. And also sleep and immunity in times of COVID-19. So if you can download and read this article, so they recommend that 7 hours of sleep is beneficial. Yeah, for in the times of COVID-19. So 7 hours sleep, that's at night time. So there's also a study they've been done that during night, especially 10 p.m. till 12 p.m., there is an increase regulation or increased secretion of growth hormone, and growth hormone might enhance the production of CD4 cells, which also will enhance the production of ER2, and ER2 is a good enhancer of humoral antibodies, so from the B cells. So it is recommended in these times of COVID-19 that if possible to get 7 hours of sleep. Prognostic, so when you get a COVID-19 patient, whether it is moderate, severe, and also critical, it is important for us to see the prognostic of this patient. It is an important issue to be discussed with the family members, and also an issue whether to maximize our therapy in this kind of patient with bad prognostic. Clinical outcomes of COVID-19 patient in Wuhan, China, around 1,000 adult patients. So they found out that compared to the not severe group, in severe COVID-19 patient, they found a bad prognostic. And what are the variables that they reported over here? That they found out that COVID-19 patient with an elevated D-dimer on admission, lymphopenia, leukocytopenia, thrombocytopenia, and diabetes. These are the independent risk factors of hospital death in severe COVID-19 patient. And these are the issues that we can use to discuss it not only with the patient, or with our colleagues, with our team members, with the patient family members, whether to proceed with further intervention or not. How about blood group, blood type, and COVID-19 infection? This is one of the good studies. So they found out evidence for association between the ABO group and rhesus positive group, rhesus positive, rhesus negative group. So looking at this picture over here, we found out that the prevalence of COVID-19 patient with AB group, it's more to get infection and intubation. It's more likely to be in the AB and the B blood group, and death is more likely in the AB group. And all of this patient, whether it is prevalence, intubation, and death, it's much more in the rhesus positive group. So should we resuscitate COVID-19 patient with cardiac arrest? So this is an issue. Okay, so cardiopulmonary resuscitation in COVID-19 patient, should we do it or should we not do it? We know that cardiopulmonary resuscitation is a highly aerosol generating procedures, and we might encounter this kind of issue anytime in our COVID-19 patient. We have to discuss this with the family members, but one of the recommendation that I found from this article is, COVID-19 patient in cardiac arrest outside the emergency department have to be evaluated for a shockable rhythm. Get a shockable rhythm, you can give defibrillator to the patient. But if it fails to restart the heart, then further resuscitation is futile. And also, if we are going to perform a cardio resuscitation CPR in this patient, we have to make sure our healthcare workers must be done with full personal protective equipment. What if we encounter a patient in the proning position and suddenly develops cardiac arrest? How should we do the CPR in this patient? Should we move back the patient to the supine position, or should we give this patient should we perform CPR in the proning position? So this is a good paper. I think you guys can further browse this paper and read. So it is about a 20 case report describing resuscitation of 25 patients in the prone position. So 20 of the 25 cases survive prone position, although few cases reported long-term outcome, usually is neurological status, and 7 cases describe full neurological recovery. So it remains reasonable to initiate resuscitation in prone position. If turning the patient back into supine position would lead to delays or risk to providers of patient. But there is the right area to perform the CPR in COVID-19 patient in the prone position. It's around between thoracic, 7 thoracic and the 10 thoracic region. This is some of the trials that has been going on in Indonesia. We are also included in the solidarity trial for COVID-19 treatments. Avigan is Favipiravir. We've been giving to our COVID-19 patient, and also there is large-scale trials of COVID-19 blood plasma therapy in Indonesia, and also remdesivir. We have been doing some discussion which patient might be beneficial to get this remdesivir, to get this favipiravir. So shortly, we in Indonesia, we're gonna again release our revised COVID-19 guidelines. So any game changer for COVID-19 patient? So I think monoclonal or polyclonal antibodies. This is humanized antibodies that can charge up or is beneficial in viral infection, and also large-scale study going on abroad also in Indonesia, probably we're going to start soon giving vaccine. There is some discussion going on. And also time to reassess tocilizumab roles in COVID-19 pneumonia. Paper I showed that is just an observational study being done. There is some issue going on that in COVID-19 patients, critical COVID-19 patient, probably moderate or severe, when you have a low EL6 level in those kind of patient, is there a role it's not a cytokine storm, probably a bradykinin storm might be going in that patient. So is there a role of giving hyaluronic acid in those kind of patient? Well, there is all these studies going on. So in my opinion, this might be the game changer in COVID-19 patient. That's all for my presentation. Back to you, Jeremiah. Thank you.
Okay, thank you very much, Dr. Gurmeet Singh, for sharing information about the management of COVID-19. And now we are moving to the questions and answer sessions. We already acquired many questions from the participants, and I will try to read this to each of the lecturers. So for Dr. Gurbilas, there is a question from Muskan from India. My question is that why smell in COVID-19 patients return only after at least of 3 months?
I think it is more of a regeneration of the neurons there. I don't see any other reason for that. The damage is done to any neuron in the body. It takes some regeneration, and probably that's the sort of time it needs for the same.
Okay, thank you very much, Dr. Gurbilas. And then we move to the second questions by Muhammad Syed Boska from Bangladesh. For admitted patients with mild to moderate symptoms with RT-PCR for COVID-19 positive, should we routinely do CT chest or D-dimer along with other general routine tests?
Yeah, Dr. Gurbilas.
No, that's for you. I think you can go ahead. Thank you.
Thank you, Dr. Gurbilas. I will also like to add for the first question. I agree with Dr. Gurbilas that it takes times for the neuron to be back in the normal state prior to infection. We can see even in stroke patients, cerebrovascular disease patients, it takes times about 3 to 6 months. That's the golden period for the patient to get back normal, for the neuron to regenerate and any other thing. So I agree with Dr. Gurbilas. And for the second question, it will be much better. It will be much better if we can do a routine chest X-ray, especially for hospitalized patient. What we're doing over here is for a hospitalized patient that is a moderate patient, moderate symptoms, and also severe. And in critical, it will be, of course, we've been doing a CT scan and D-dimer. Not only we can evaluate the prognostic of the patients, because we never know these COVID-19 patients, when will they develop this progression from the moderate symptoms to severe to critical. It's not that clearly shown, but we can use some prognostic, which I showed that, chest CT you can do, and also a D-dimer test, probably to anticoagulate the patient. Thank you.
Okay, thank you very much.
Maybe some advice from Dr. Gurbilas.
I would say a CT is a very good test. A high resolution CT is a very good test to risk stratify as well. D-dimers, they can be non-specific, but anybody with the significant symptoms must undergo a CT chest, as we discussed in the talks.
Okay, thank you very much, Dr. Gurbilas and Dr. Gurmeet. And this is a question for Dr. Gurbilas from Kevin in Indonesia. How long can COVID-19 virus survive on the surface of an object?
So to that, we can say various surfaces will have different times for the virus to survive. I think initially it was mentioned metallic surfaces will have the virus for several days, and something like a fabric would have it for a few hours. So various surfaces, various time periods for the virus.
Okay, thank you very much, Dr. Gurbilas. And that is the first 3 questions for Dr. Gurbilas, and we move to the first 3 questions for Dr. Gurmeet. This is from the Muhammad Syed Boska, but unfortunately, this will be answered in the tomorrow sessions because we have another session for the vaccine development by Dr. Santos. And the second question is by Ashi Khanna in India. Many people believe that drinking hot water and taking steam may prevent you from COVID-19. Can taking regular steam and drinking hot water really prevent the people from the COVID-19?
Oh, yeah, okay. Thank you. This is a good question. So, in the early stage of this pandemic, I've been also seeing like videos, reading some articles about drinking hot water and taking steam may prevent you from COVID-19. So, right now there is no ongoing trials about this taking steam, but there is a paper. Also, I shared in my PowerPoint that fever is good. Actually, fever is good for COVID-19 patients. Yeah, also for any other viral patients up to 39 degrees. So, and there is also a paper, an old paper about taking hot and cold showers. So what they found out over there is while heating up the patient, like in sauna, up to 39 or 40 degrees, it can enhance your innate immune system. And after that, taking a cold shower will further enhance your immune system. So looking at results from those papers, in my personal opinion, yeah, it's good to take like a hot water and taking steam. Not it might not prevent 100% someone from getting COVID-19 patient, but it might reduce the chance of someone of getting a COVID-19 patient. Even me myself, I've been drinking hot water and also taking these cold showers, hot and cold showers regularly. That's
On a
from
lighter note, if I may add in, I've had a couple of patients who have had deep burns on their legs while taking steam. They accidentally dropped hot water, so one has to
yeah.
be very careful.
Yeah. I agree with you, Dr. Gurbilas.
Okay, thank you very much, Dr. Gurmeet and Dr. Gurbilas. We move to the second question. I think this is more for Dr. Gurbilas for the diagnosis. It's is it possible for coronavirus to pass through the placenta from T. Tekiang from Malaysia?
So what we are talking here is vertical transmission of coronavirus. To the best of my memory and knowledge, I think there was a study from Italy, a small one, in which they saw that there can be vertical transmission of coronavirus. I don't remember the details of the study, but I do remember that a small number of mothers transmitted the virus to the newborn. So yes, it is possible.
Okay, thank you very much, Dr. Gurbilas. So we move to the next questions from Tanis from India. What's your opinion on the interim results of the Solidarity trial by WHO, which is rejected hydroxychloroquine, lopinavir, ritonavir, and the interferon? Dr. Gurmeet?
Yeah, thank you. Indonesia is also one of the country included in this Solidarity trial. Probably, I think India must have been included also. So the result was they rejected hydroxychloroquine earlier enough in the study. So we've been recruiting, let's say, 5 group of patients, standard care, hydroxychloroquine, lopinavir, ritonavir, interferon, and one other, I forgot one other group. So they stopped this hydroxychloroquine group or treating patient with hydroxychloroquine even before they did an interim results. Probably from outside results also suggest that there is no benefit hydroxychloroquine, lopinavir, ritonavir, interferon. But looking from some results, they've been showing like probably some combination therapy in South Korea with lopinavir, ritonavir, and with interferon. They've been giving some positive results. Even though in Solidarity trial they give like separate antiviral treatments, but probably combination therapy they have been giving some positive results as well. For hydroxychloroquine, I've been giving to my patients has what do you say, zinc ionophore. So whenever I give zinc to my patient, I will add hydroxychloroquine, because I shared that hydroxychloroquine is one of the best for zinc ionophore. It can enhance the uptake of zinc into the cells. That's it from me. Probably about hydroxychloroquine prophylaxis, I'm not so sure about that, but I think also they don't give a positive point for hydroxychloroquine prophylaxis. Probably Dr. Gurbilas has much more experience about this hydroxychloroquine prophylaxis in India.
I'm saying that I have not taken it myself. Many of my colleagues did. I think now's the time when most of them are forgetting taking it also. So they don't remember when they last took it, whether it was 2 weeks ago or 1 week ago. So what I'm trying to say here is, I think we have learned to live with it now, and we are being more careful. Initially it was a big knee-jerk reaction that everybody must take prophylaxis with hydroxychloroquine, and then there were some mixed responses about it. We were not sure what's happening. I think we have not seen such a situation in the world for the last many years, in our lifetimes at least, where we are not sure of what to do. This is an evolving thing. Nobody's sure. Maybe 10 years hence, we would be much wiser as to what should have been done, as is with most diseases. Right now, I would simply say many of my colleagues have stopped taking hydroxychloroquine prophylaxis, and solidarity trial, the drugs have not been shown to be much effective. But as you've already mentioned much of it, so I would just add that much. Thank you.
Okay, thank you very much, Dr. Gurmeet and Dr. Gurbilas. Moving to the next questions from Muhammad Syed Boska. WHO said
that... let me just answer the second question about remdesivir.
Yes.
Remdesivir should we use this drug for treating severe or critical COVID-19 patient? I shared one study, that the recovery study over there. So what they found out is there's no benefit in giving remdesivir in patient other than the need for low dose oxygen therapy. So patient in severe, they need this high flow nasal oxygen therapy. Patient critical, they are intubated. There's no additional benefits from that trial, but it comes back again to our national guidelines. And for the third question, significant side effects. Favipiravir, the side effects, one is liver enzymes. Patient can get elevated liver enzymes, hyperuricemia. And there is also one issue that has to be discussed with the patient. A female COVID-19 patient, which will be taking this favipiravir, we have to test a pregnancy test just to make sure that the patient is not pregnant, has favipiravir have some teratogenic effects. And also in male patients, there is some effects of reducing the the sperms in the male patient. So this is one of the issue also to be discussed with the patient. And probably we should also inform the patient of not to do any intercourse, as we know that it can be secreted in the sperms. And for tocilizumab, we have to make sure that, yeah, it is a cytokine storm going on. Tocilizumab inter-IL-6 is high. And one of the side effects is it will suppress your immune systems. It can activate secondary bacterial infections, activate also some tuberculosis infection. So we have to make sure that the patient doesn't have or is negative for any bacterial infection. And it will be quite difficult. So in our institution, we usually have a COVID board meeting to discuss whether or not to give this anti-IL-6 in this patient. For remdesivir, there is a slight increase in the kidney function test. So I think we have to evaluate kidney function test before giving this remdesivir. That's all from my side.
Okay, thank you, Dr. Gurmeet. And we're moving to the next panel of questions for Dr. Gurbilas. Karthik from India, can allergic rhinitis from symptoms like sneezing, redness, and irritation of eye and nasal discharge superimpose on the COVID-19 symptoms?
Since we've already said that we should not assume things, and if there is any concern, best is to get tested. Now, redness of eye, sneezing, as well as a nasal discharge, they are not the common symptoms, but if there is fever with it, and if there are any other signs that suggest it could be COVID, and if a clinician, I wouldn't put this power in the hand of a patient. If a clinician feels it's appropriate, it should be done. I, as a clinician, and I'm in a favor of doing more tests, as many as possible, to reach out and to confirm how many cases we are actually seeing. Thank you.
Thank you very much, Dr. Gurbilas. And can you please brief us about the Crispr test, the Feluda test?
I think Crispr test is one of the very latest ones, which is very, very quick, I think, but I'm not sure whether it's validated or not. Dr. Gurmeet Singh, do you know anything about this?
Yeah, I've just read a little bit about this CRISPR test. So usually this is I should say a DNA sequence usually been used for bacterial infection, but there are some studies going on. I've not gone through the majority of the studies that it might give some benefits for antiviral also, but like it play a key role in the antiviral defense system. But I have not gone through deep enough in this paper, Dr. Gurbilas.
Yeah, frankly, I don't think it's validated as of now. It may be one of the tests which comes, I think what I remember of this is that it takes very little time to come back as a result, and it's very, very clear and, confirms. But I don't know about the validation yet. Thank you.
Okay, thank you very much, Dr. Gurbilas and Dr. Gurmeet. And we move to the questions from Muhammad Syed Boska from Bangladesh. As SARS-CoV-2 can be found in stool sample, can we say that this virus is also transmitted by orophageal route?
Certainly, there was one instance from Wuhan where a flat was sealed, affected individual's flat was sealed, and then later on when they took samples, in the toilets, it was full of the virus. Now, fecal-oral route, how significant is that? That is very significant, of course, but if we wash our hands, we break the chain. So certainly we know it's in the stool. Fecal-oral route may be able to spread the virus. That is why the 3 W's that we talk about, washing hands is very important. And as in any other virus, hepatitis A, hepatitis E, we can easily break the chain of fecal-oral route by simply keeping our hands clean. Thank you.
Thank you very much, Dr. Gurbilas, and we move to the next question panel from Ashikarna in India. What could be the possible opportunistic infections in COVID-19 patients for Dr. Gurmeet?
Okay, that's a good question. I haven't gone through any paper about the possible opportunistic infection, but what I've been seeing in our critical COVID-19 patient here in my institution, that once they are intubated, I've been performing bronchoscopy procedures in these patients. So I found like secondary bacterial infection, usually Acinetobacter baumannii, we got a Pseudomonas infection, that possibly secondary infection, whereas opportunistic infection, like I mentioned before, probably could be due to anti-IL-6 therapy in this kind of patient, but I've not been seeing any opportunistic infection in COVID-19 patients yet now.
Okay, thank you very much. We move to the next questions. Is it possible for coronavirus recurrence? If it can do recurrence, is the clinical and prognosis getting worse? And what is the difference?
Sorry, who's? Yes, Gurmeet, go ahead, please.
Yeah, thank you, Dr. Gurbilas. So it's possible to get a reinfection of coronavirus. There have been some case reports. So usually a person might be reinfected probably in the range of 2 to 3 months after the previous infection, but also it depends on the antibody levels and the state of the COVID-19 patient. If he or she develops mild to moderate COVID-19 patient, probably the antibody level is not that high compared to severe or critical COVID-19 patient. And is the prognosis getting worse? Whereas there's one also issue that we have to make it clear, whether is it a reinfection or like we have a case over here in my institution. We are just discussing also whether is it a case of post-inflammatory, post-infection inflammatory syndrome. So we have got a case over here, patient female developed COVID-19 in the month of September, 29 September, positive for RT-PCR. So she was totally fine, and she came back again with severe COVID-19 and develop progress into critical COVID-19. We have to intubate the patient. Swab test from the nasopharyngeal swab was negative. And I performed the bronchoscopy yesterday only. So we got the result and it came out to be positive. But there's an issue like last month she was positive for COVID-19, swab test is negative. Usually I read a paper that COVID-19 SARS-CoV dies after 8 or to 10 days since symptom onset. So probably this might be due to post-infection inflammatory syndrome, but I think we have to further discuss this matter. Thank you.
Okay, thank you very much, Dr. Gurmeet. And I would like to move to the next question. What could be the possible ways and treatments with less side effects for the cytokine storm in the COVID-19 patients, Dr. Gurmeet?
For the cytokine storm, we have to make sure whether is it a cytokine storm or is it just hypercytokinemia. In mild to moderate, whether it's bacterial infection, it's viral infection, you have a elevated IL-6 level in your blood, probably this is a hypercytokinemia. Yeah, and if you have a high IL-6 level in a critical ill, in a severe or in a critical ill COVID-19 patients, that's probably due to cytokine storm going on in that patient. So light side effects probably might be because of the medication that we're going to give. Over here, we have been using tocilizumab therapy in those kind of patients. We have to make sure there is no secondary bacterial infection, or if there is secondary bacterial infection, usually patient in critical ill, so they already develop pneumonia, so we give antibiotics to the patient. Probably we have to make sure no fungal infection, and the third one is like I mentioned before in the further question, probably opportunistic infection like tuberculosis have to be evaluated. That's all.
Okay, thank you very much. And for the second questions, I think we already answered that in the Dr. Gurmeet lectures about the treatment protocol and the criterion for hospital admissions. So we move to the third question for Dr. Gurbilas. This is there is a development device that detects a violate organic compounds as a result of SARS-CoV-2 infections in breath. So people just need to breathe in order to diagnose COVID-19. What do you think about the breath test like that?
Well, I think the sensitivity will be pretty low here, and it would require validation anyway. You know, if we were catching a lot of virus in the breath itself, it will be very dangerous, and the spread would be much more. So I would say such a test may carry a very low sensitivity, although it may sound very easy to do, just like an alcohol breath test that the police do for offenders. This may be something very easy to do, but I would be very skeptic about such a test. What do you think, Dr. Gurmeet Singh?
Yeah, I agree with you, Dr. Gurbilas. So they're developing, like they say, this breath test, but it's quite dangerous also to perform this breath test, like Dr. Gurbilas already mentioned before. If he or she is positive for COVID-19 and doing this breath test might spread out this virus in further.
Yeah. Thank you.
Okay, thank you very much, Dr. Gurmeet and Dr. Gurbilas for the answer. And we are moving to the next question from KM Tigas, India. Why do doctors suggest patients to have vitamin C and zinc supplements when they are in home isolation? Dr. Gurmeet, please.
Yeah, about vitamin C, I've been reading some articles. Vitamin C, high dose vitamin C is beneficial in septic patient, in shock septic patient. But I haven't found any articles about vitamin C supplements in COVID-19 patient. As for zinc supplements, like I mentioned before, yeah, zinc has a role in COVID-19. Also, zinc plays a role in cellular immunity. Zinc supplements together with zinc ionophore gives a positive results in COVID-19 patient, and I prescribe zinc supplements and zinc ionophore to my COVID-19 patient.
Okay, is there any opinion from Dr. Gurbilas?
I think vitamin C and zinc both are known to have been good for a person's immunity, and that is reason enough to use it. Vitamin C also prevents common cold, so that there is no overlap, and so that otherwise we are hale and hearty and healthy. I myself would say this, that I have never worn masks before, maybe except in the hospitals and in the operation theaters, yes, but outside we have never worn masks before. And I personally have felt that, going out now, I don't get the normal rhinorrhea, my normal allergies that I used to have regularly. So I feel much better. There are certain things like vitamin C, which have been validated and which are well known to, avoid common colds and treat common colds rather than, use of antibiotics, which is rampant in a country like India. So in my practice, I've been using vitamin C for a long time. And it does have good results. Also with anemic patients and other things, vitamin C is a good drug anyway. It's just a supplement, really. So thank you very much.
Okay, thank you very much, Dr.
And also, Jeremy, and also I would like to add also, vitamin supplementation is also beneficial when patients are in home isolation or patient in hospitalized for COVID-19.
Okay, thank you very much, Dr. Gurbilas and Dr. Gurmeet. We move to the next patient. Patient with mild symptoms but newly detected silent hypoxia or happy hypoxia. Should we admit the patients to the hospital right away, Dr. Gurbilas?
So, well, mild symptoms, it just depends on what a clinician feels about it and how the patient is. Like, if I may say, my patient, Mr. B, he did not have any significant symptoms, but ultimately we had to admit him to the hospital because of various reasons. So it wasn't because of his COVID status being negative or positive, or his saturations, which were like 93. He wasn't really short of breath, but he had several other symptoms, which may be because of anxiety. If a patient lands up in the hospital emergency for any reason, and although the saturations may be borderline, say just 93, 94, and he is a little short of breath, which may be subjective because his respiratory rate otherwise is not really labored. It just depends on a clinical scenario. There are set protocols which we follow, but this is a case-to-case thing and a clinician-to-clinician thing, depending on the resources as well. In a country like India, where a patient is in control and wants to be admitted, it comes to that. But when the bed strength goes down, when we don't have beds, then we have to case stratify in a slightly different way. So I would say there are set protocols. We follow them all the time. But the most important thing is what the clinician feels about a particular patient. Thank you.
Okay, thank you very much. I think this is the end of the question and answer sessions. We are apologize for every question that left unanswered. I will come with an answer soon if that is possible. And we would like to thank you, Dr. Gurbilas and Dr. Gurmeet, for sharing such important and useful information for this webinar. And I would like to present the certificates electronically in these presentations to Dr. Gurbilas and Dr. Gurmeet. This is the certificate for the Dr. Gurbilas, and I will take a screenshots with Dr. Gurbilas and the certificate in 1, 2, and 3. Okay, and then we move to the Dr. Gurmeet. Thank you, Dr. Gurmeet, for your presentations, and we will take the picture with the certificates in 1, 2, and 3. Okay, this marks the end of the day 1 of the AMSA International Webinar Series, Current Approach Towards COVID-19. I hope we all get the useful informations and beneficial informations towards the management and diagnosis of the COVID-19. I would like to recap the information from the 2 lectures in one resume. There is no assumptions in the diagnosis towards COVID-19. which is we can see the most common symptoms is the fever, dry cough, and tiredness. And there is less common symptoms, but we must be also aware about it. And hypertension, obesity, and diabetes is the most factor contributing to the severity of the COVID-19, with the elderly is more at risk of the COVID-19. And we can see from the presentation that RT-PCR, RT-LAMP, and antigen assay is the most common methods and the most sensitive and specific methods used for the diagnosis of COVID-19, which we also can use the CT scan, but not preferably X-ray. Tracing and surveillance is very important to make sure that everyone gets diagnosed with COVID-19 and for the prevention measures of the COVID-19. And we must keep updated about the current diagnosis of COVID-19 because it is an evolving knowledge, so we must keep reading and keep updated. And we know from the Dr. Gurmeet's lecture that bronchoalveolar lavage is the most diagnostic tools for the COVID-19, but not often used, only in critically severe patients. And we can see that there is outpatient and inpatient criteria of the COVID-19 patients, which is for outpatients criteria, we do not have to use aggressive medications toward the patients. And for the inpatients, we can do something to list their severe and critical symptoms. And we know that there are many antiviral which is developed, and we know that favipiravir has shown superior effects as the antiviral of choice of COVID-19. However, it is not decided yet, and then the study is still evolving. And we know that there is many methods that could list the COVID-19 symptoms, such as doing a prone positions and giving corticosteroid, and then the anticoagulant based on the symptoms and then the clinical findings. Therefore, managing the patients according to the laboratory findings and clinical findings is very important to decide which medications is suitable for every patient, because the medication of the COVID-19 is patient-tailored. So it's tailored for each patient's different medications. And for the correct medication, we must do clear anamnesis, physical examinations, and supportive examinations. And another non-medication measures such as sleep and hot water and vitamin supplementations is very important also. And don't forget that we can do CPR for critically ill patients, especially in prone positions. And we also must keep updated about the current information about the COVID-19. I think that's all for today. I would like to say thank you for all participants joining and hope you have a nice day and see you tomorrow. Thank you very much.
Thank you, Jeremiah. Thank you, Gurbilas, sir.
Thank you. Good to see you.